Hello everybody, I'm Dr. Sadaqati, a gynecologist, and welcome to my channel OB-GYN Study. And today I'm going to talk about the POI, or Premature Ovarian Insufficiency, and POF in the past, Premature Ovarian Failure. What's the definition? Premature ovarian insufficiency, also known as primary ovarian insufficiency, is a condition characterized by loss of ovarian function before the age of 40, leading to estrogen deficiency and infertility. It's diagnosed based on elevated FSH levels more than 25 international units per liter on two separate occasions at least 4 weeks apart, and low estradiol level, indicating ovarian failure. Unlike menopause, where ovarian function ceases permanently, POI is associated with intermittent ovarian activity, meaning ovulation and spontaneous pregnancy are still possible in 5 to 10% of cases. What are the etiologies? The causes of POI can be idiopathic. It's the most common, 75 to 90% of cases, or secondary to genetic factors, autoimmune diseases, iatrogenic causes, metabolic disorders, and infections. What are the genetic factors? Turner syndrome, fragile X premutation, FSH receptor mutations. What are the autoimmune diseases? Autoimmune ovaritis, Addison's disease, autoimmune thyroiditis, and type 1 diabetes. And what are the iatrogenic causes? They are chemotherapy, radiation therapy, bilateral oophorectomy. And what are the metabolic disorders? Galactosemia, 17-alpha hydroxylase deficiency. And what about the infections? Mumps, ovaritis, cytomegalovirus, and tuberculosis. How we can diagnose the POI? Clinical presentation. Menstrual irregularities, symptoms of estrogen deficiency, infertility, and associated autoimmune disorders. Menstrual irregularities like oligomenorrhea or secondary amenorrhea, and symptoms of estrogen deficiency like hot flashes, night sweats, vaginal atrophy, dyspareunia, mood swings, cognitive dysfunction, and infertility due to anovulation or poor follicular reserve, and associated autoimmune disorders like hypothyroidism and Addison's disease. What about the laboratory and imaging investigations? We have hormonal tests, genetic tests, pelvic ultrasound, and BMD, or bone mineral density testing. Hormonal tests include FSH more than 25 international units per liter, measured twice at least 4 weeks apart. Low estradiol less than 50 picograms per milliliter. AMH, or anti-Mullerian hormone, low levels suggest diminished ovarian reserve. LH, or luteinizing hormone, is elevated. Prolactin for rolling out the hyperprolactinemia. Thyroid function test to exclude thyroid dysfunction. Adrenal antibodies to rule out autoimmune adrenal insufficiency. What about the genetic testing? Karyotyping to detect Turner syndrome or translocations. FMR1 gene analysis to assess fragile X premutation. The other investigation is pelvic ultrasound. In ultrasound, we have small ovaries with no or few antral follicles, and ovarian volume less than 1.5 cube centimeters suggests ovarian failure. And the last one is BMD, or bone mineral density, recommended to assess osteoporosis risks due to estrogen deficiency. Now, we should know about the treatment. What are the treatments of POI? We have HRT or hormone replacement therapy and non-hormonal therapy. Hormone replacement therapy is the first-line treatment to manage symptoms of estrogen deficiency and prevent osteoporosis and cardiovascular disease. Recommended regimens are estrogen therapy can be given as oral, transdermal, or vaginal formulations. Progesterone therapy needed for endometrial protection if the uterus is intact. Oral HRT. We can prescribe estradiol 1 to 2 mg per day plus MPA or medroxyprogesterone acetate 5 to 10 mg per day for 12 to 14 days per cycle. For example, the prescription is estradiol 2 mg plus MPA 10 mg for days 15 to 28 of each cycle. Another oral HRT is CEE or conjugated equinestrogens 0.625 to 1.25 mg per day plus MPA 5 to 10 mg per day. Another option is transdermal HRT for those patients at risk of venous thromboembolism or VTE. Estradiol patch 50 to 100 microgram per day plus micronized progesterone 200 milligram for 12 to 14 days per cycle. We can use continuous combined HRT for women more than 50 or long-term users. Estradiol 1 mg plus norethindrone acetate 0.5 mg daily. Another option is a vaginal estrogen for vaginal atrophy or dyspareunia only. Estradiol 0.5 mg vaginal cream twice weekly. Duration of HRT until the average age of menopause around 50 years, after which risks and benefits should be reassessed. Okay, the other treatment is non-hormonal symptom management. For example, SSRIs or SNRIs like venlafaxine, 37.5 to 75 milligram per day for vasomotor symptoms in women who cannot take estrogen. The other one is gabapentin, 300 to 900 milligram per day alternative for hot flashes, and lubricants and vaginal moisturizers for vaginal atrophy. What should we do about fertility management? Spontaneous pregnancy is rare but possible 5 to 10% of cases. Ovulation induction, for example, clomiphene or letrozole is usually ineffective, and ART or assisted reproductive technology like egg donation plus IVF is the most effective option, and experimental treatments like stem cell therapy or ovarian tissue transplantation are under research. Another aspect of treatment of POI is prevention of long-term complications. About the bone health, osteoporosis prevention, calcium 1000 to 1200 milligram per day, plus vitamin D 800 to 1000 international unit per day. Another one is bisphosphonates, for example, alendronate 70 milligram weekly in severe cases, and weight-bearing exercises to maintain bone density. Another aspect is cardiovascular risk reduction. We should monitor lipid profile and blood pressure regularly, lifestyle changes, for example, healthy diet, exercise, smoking cessation, and mental health support. We should have psychological counseling for anxiety and depression, and support groups to help with emotional adjustment. Thank you for your attention, and bye for now.